of varying severity in different pathways. Diabetes was classified long back by even in India also by Sushruta and Chakra. Along with that, there is a WHO classification which is talking of type 1 and type 2 diabetes. But you know that before that we used to call it a diabetes which is NIDDM or IDDM, which has been now stopped. We are using a classification of diabetes as a type 1 and type 2. But as I told you, the type 2 is not same. It is with different varieties of type 2 diabetes there. But before this, we were knowing only type 1 diabetes in a different varieties like LADA or young diabetes with a MODI. Then there are few patients of secondary, but type 2 diabetes are a multiple variety. This was a first paper which was from Dr. Leaf Group in March 2018. There is a novel subgroup of adult onset diabetes and their association with outcomes. This was a paper which had talked about the type 2 diabetes is actually not a single type. It's a multiple varieties. The cohort which he had used is the cohort which is from all new diabetics in Scania, around 8,980 patients with a new onset of all type 2 diabetes. Then there was a cluster variable they have done for each and every patient. Get autoantibody, A1C at the time of diagnosis, BMI, age at the time of diagnosis, C-peptide base, HOMA2 beta cell secretion, and C-peptide base HOMA2B insulin resistance. And two clustering methods which they had used, and what they found that actually diabetic patients are having 5 varieties. The clusters was not a same. So one variety which we call as a type 1 diabetes or a LADA, which in this particular cluster classification for all diabetes, they call is a severe autoimmune diabetes. So this diabetes remains same, a type 1 diabetes, or we call it, some of them are LADA, latent autoimmune diabetes of adult. They are misclassified sometimes a type 2 diabetes, but these are the patients who have autoantibody positivity. They have very low C-peptide, and this they called as SAID, which is severe insulin autoimmune diabetes. Now, type 2 diabetes is actually classified into 4 groups. The type 2 diabetic patients, there are 18% of the patients, they were not having autoantibody positive. They were not like very low insulin secretion like type 1, but still they have low insulin secretion and a poor metabolic control, and they call it a SID. It is a severe insulin deficient diabetes. The other 15% of the patients were in a different class where these patients were highly insulin resistant. They were a bit obese. Their diabetes was not like very young boys, slightly late onset, and they were having very high insulin resistance, and they called them a severe insulin resistant diabetes, which is third. The third variety is actually obesity is a primary driver for them to induce diabetes, and they call it is a moderate obesity related diabetes, which is MOD, which is moderate obesity related diabetes. 39%, which is very high number, almost 40% of our patients are actually age-related diabetes. They are having late onset and they are comparatively good metabolic control, and they call this MARD, which is moderate age-related diabetes. This replication of clustering was not only done in Scania diabetes registry, but all over the world, and many more registries they have done. So ANDIS was the primary where they have done this clustering in 8,980 patients. Then there was a Scania diabetes registry of 1,466 patients with a diabetes duration of less than 2 years. Then they have done in ENDU where the 844 patients with duration of less than 2 years. Then they have done in VASA diabetes registry with a diarrhea, again less than 2 years with a number of 878, and there was one more diabetes registry where they had 2,607 patients with a duration of less than 2. But one thing which they had seen in all these different registry, that these 5 varieties you can find in all these type of registry. It means everywhere you will get around 6 to 10% of the patients who are with SAID, which is cluster 1, which is severe autoimmune diabetes. You will get around 18%, which was there, but around 15 to 20% of the patients were severely insulin deficient, which is called SID. Then a third variety was again between 15 to 20%, which was SERD, which is severe insulin resistant diabetes in all these registry. Then there was a class which was around 20 to 25%. It is MOD, which is moderately obesity diabetes related diabetes, which was also there almost in all these clusters. And the last was a moderate age related diabetes, MARD, which was also there almost in 40% of the population. So, I mean, this is what the same clustering which was done in ND's registry was again done in other registry, and they found that almost similar type of number of patients were there, and they could be classified in these different four varieties of type 2, and one which we call is a SID, which is SAID SID, which is like a typical of type 1. Even not only that, other than Europe, they had tried to also replicate same in China and US population too. And there, actually, there was no GAD autoantibody was done. So it was done in type 2 diabetes only, and only 4 clusters were classified. And this China National Diabetes and Metabolic Disorder Study, where cohort was almost 2,318 patients, and MARD was still there almost like in 45.1. So the moderate age-related diabetes was there in 45.1% of the patient. 13.5% of the patients were having severe insulin deficiency. 8.6% of the patients were having severe insulin resistant diabetes, and obesity is still almost 32.7. So the primarily they were having either MARD or MOD, which is in the Chinese population. If you see from the US population, which is a National Health and Nutrition Examination Survey, this cohort of 685 patients, and they also found almost similar type of number as what we had seen in the Chinese population. Similar type of data was there from the US population also. So this replication of this type 2 diabetes in a different cluster was done not only in European population, but also in Chinese and US population too. Why the clustering? Is there any difference in response to treatment? Yes, the metformin will be, or the glitazone will be higher with the, they will be more responsive with the patients who have severe insulin resistance. Metformin will be useful more with the patient who have SERD or MOD or MARD in compared to the patient who have SID, and sulfonylurea is a molecule which will be more beneficial in the patients who have MARD. So, I mean, this was the response which they could see, but still more papers are required as far as these clusters, how they will behave as far as therapy is concerned. But one thing was very clear in all these things: the patient with SID, severe insulin deficient diabetes, they require probably early insulin therapy. That is what had come in these clustering method. This non-alcoholic fatty liver disease was more common with the patient with severe insulin resistance syndrome, and thus the reason the glitazone and the metformin is more useful for these. Now, classifying these type 2 diabetic patients, they had created a software. And this software was in computer algorithm. As soon as the patient who is newly detected diabetes coming to your center, just put all the data and get their C-peptide autoantibody, and you will get that actually this patient is belonging to what type of cluster. You can have a fair amount of idea by just putting the data on your computer. This online tool for classification is there. It will be available to all over the world once this concept of classifying type 2 diabetes will be well established. Now, more important question is, can this be applied to Asian Indian population? That's a very important question to us, mainly to our Indian population. And before that, as we know that we type 2 diabetic patients in India are different than what Western people are. We are having the age of onset of diabetes at much lower. We have lower BMI to get the diabetes, and our patients also have higher insulin resistance, and at the same time rapid decline in beta cell function. So these are some of the very important things which we have in our Indian South Asian phenotype or Indian phenotype, which is different, and we have more of a central obesity and abdominal obesity in compared to the patients who are in Western population, which they don't have higher muscle mass, rather we have low muscle mass also. So this paper, which was published from V. Mohan and group, the Dr. Anjana was the first author, and they had talked about in novel subgroups of type 2 diabetes and their association with microvascular outcome and an Asian Indian population, a data-driven cluster analysis, an inspired study, which is been published in BMJ Open Diabetes Research and Care. And what they found, they tried to classify the same patients in those 4 groups. I mean, the number of the patients they tried to classify in the same 4 groups, SID, SERD, MOD, and MARD. And what they found actually are the obesity is not the major driving force for India, type 2 diabetic patients. So we could find there is some difference. And this cluster analysis they have done in different centers of Dr. Mohan Specialty Center across 9 states in our country with 19,084 patients. So it's a big number of patients in this cohort particularly, but the duration of diabetes for these patients were less than 5 years, not less than 2 years. That was slightly different. These patients were having age at the time of diagnosis, BMI, waist circumference, A1C, serum triglyceride, HDL cholesterol, C-peptide, and C-peptide stimulated. These 8 parameters which they have taken, because they have already taken these parameters when patient was getting admitted, getting OPD consultation at these centers. And they could find out, instead of that type 2 diabetic population, where there 4 type 2 cluster, here there are 4 novel clusters which they could find in Indian subpopulation. SID was there, but it was slightly higher. We were having not 18%, it was 26.2% severely insulin deficient diabetes. They are having early onset, low BMI, low HOMA-B, low HOMA-R, IR, and low C-peptide level. Now, this is very interesting. A new classification, a novel cluster they could have is a IROD. It is a insulin-resistant obese diabetes. As I told you, we don't have many patients with obesity, severe. So that MOD, which is moderate obesity diabetes, that type of classification or that type of cluster we could not have. Rather, we have a similar type of cluster, which is SIRD, which is severe insulin-resistant diabetes, SIRD. So almost similar we could have in a IROD, insulin-resistant obese diabetic, which we can call insulin resistance, higher BMI, and high C-peptide level. It is almost 1/4 of the patient. The third, which is 12.1, which is a very novel, it was not found anywhere. It is combined. It is a combination of both insulin resistant as well as deficiency. And what we had seen, these patients have higher HOMA insulin R, but they have HOMA beta cell is low. They have a high triglyceride, but they have combination of insulin resistance as well as combination of insulin deficiency. We were also having almost 1/3 or more than that, a patients who are moderate age-related diabetes. They are older, they are having the highest HDL cholesterol, and they are fairly preserved C-peptide level. So the clinical and biochemical characteristics of various type 2 diabetes patients in a subgroup level, they could see the cluster 1 in a SID patients were having the lowest BMI, the waist circumference was the less, and they were having uncontrolled diabetes with C-peptide of 0.8 only. While the patient with IROD, with the insulin-resistant diabetes, they were having higher C-peptide level. In the group out of 4, they were having the highest. The cluster C, third, is a combined insulin deficiency and resistance. Both were there, and one was the resistant symptom, or the triglyceride level was high, and their C-peptide was not as high as IROD, but still it was not low also like SID. Then they were having moderate age-related diabetes. Here the age of these persons were higher, more than 50 plus minus 10.3, and their C-peptide was relatively preserved, and with good metabolic control was also seen with these patients. So these 4 type 2 diabetic patients was classified in a different clusters in an Indian study done by Mohan and group, and they were having almost 3 different, same almost, but one cluster which was very unique, that we have combined insulin resistance and combined insulin deficiency too. Then we tried to do the same data in a bigger population. So the validation of clustering in a nationally representative epidemiological data set. As Dr. V. Mohan is a principal investigator of ICMR in diabetes study, and he had taken the sample size of 4,000 representative samples from all states and union territory. The sample size for validation was, after doing this, it was 2,204 from 15 states. These variables were used: age, BMI, waist circumference, A1C, triglyceride, and HDL, because C-peptide was not done in this group. So that's the reason that is being removed, and they tried to do nationally representative study, ICMR in diabetes study. From their 4,000 representative sample were taken, and 2,204 samples were sample size was there for validation. And what they found, almost similar 4 varieties of cluster could be found in this nationally validated sample size. And what they had seen, the SID is almost same. The similar way of MARD, which is almost 55 plus minus 9.8 year. And then they were having a insulin resistant diabetes, and they were having also the combined insulin deficiency and resistant diabetes. Both were present in a unique group of patients. So even without C-peptide, they could classify these patients in a 4 clusters. In a diabetes clinic, where we may not do the C-peptide for each and every patient, but this can be done. This classification can be done with very easy 6 simple variables: age at diagnosis, BMI, waist circumference, A1C, serum triglyceride, and HDL cholesterol. Now, what next? I mean, is it over? No, we are looking for other ethnic cohort in India. So that's the replication. Is it we are getting the similar four varieties like Sweden people have published, or the variety which is published by Mohan and group? We have to decide what is individualized treatment, because different clusters will have a specific treatment. So we are moving from individualized treatment to probably a precise or a personalized treatment. The pharmacogenetics we will able to know better. Can we identify these patients with a pre-diabetic phenotype? And on this basis, can we develop a clinical decision support system? If you have a patient of this variety, accordingly, you can treat these patients. To summarize my talk, there are 3 severe forms of diabetes: severely autoimmune diabetes, SAID. Then we have severe insulin deficient, and we have severe insulin resistant. 2 are moderate, it is obesity related or age related diabetes. As I told you, SID is a patient with the highest risk of diabetic retinopathy and neuropathy, while SIRD has highest risk of diabetes, kidney disease, and NAFLD. Important not to focus only on A1C to evaluate disease progression or response to therapy. SID and SIRD patient develop complication very early and would benefit from early identification and treatment. Classification can be done at diagnosis based on NDIS cluster, could be useful in clinic to predict risk of complication and guide choice of medication. First time in India, the clustering was done in individual with type 2 diabetes using 8 clinically relevant variables. The novel cluster CIRDD is of particular importance as it is characterized by difficult to control hyperglycemia and increased risk of kidney disease and retinopathy. With this, I thank once again, thanks to all of you and rightdoctors.com for giving me an opportunity to share my views on this very important topic on a novel classification of type 2 diabetes. I have few questions which I would like to answer, because some of the questions which are there, so we would like to have one by one, and we will try to answer all those. But still, those who have the questions even after this talk, they may again directly ask, and we would definitely like to answer those questions also. So I already stopped my screen, and now I'm answering some of the question which is asked. One of the question which is from Dr. Maitre: why do patients with diabetes show depressive symptoms? Is any chronic disease, if any person is having any chronic disease, most of them, they will feel sometimes that now this is lifelong, I can't do anything more, and I have to restrict my diet, I have to do exercise, and sometimes they are restricted because of some other activities, from other activities, and this leads to depression. There is a Dr. Abhishek Das who is asking me for vitamin D directly, does it have a direct impact? Yes, those patients who have low vitamin D, they are found to have higher metabolic syndrome. They are the one who are getting more diabetes. But that does not mean just by taking the tablet vitamin D, will it decrease the incidence and of type 2 diabetes? Yes, definitely by doing more exercise and getting sunlight directly will decrease not only diabetes, but will increase the vitamin D level also. Dr. Vaibhav Das, how does TNF alpha improve bladder dysfunction in type 2 diabetes? TNF alpha is actually a marker of inflammation. The patient with diabetes with having bladder dysfunction is a part of autonomic neuropathy. Some of the patients, because of urinary tract infection also, they have the bladder dysfunction, but mainly it occurs with patients with diabetes neuropathy. In an advanced case of diabetic neuropathy of using with the bladder, this autonomic dysfunction, actually speaking, not a single treatment is available. We have a good glycemic control, will help definitely these patients, but intermittent catheterization is sometimes the only answer with the patient with diabetic autonomic nervous system dysfunction. Now there are medication which we give, the urologist would like to prescribe them for better control of this urinary bladder which is getting affected because of diabetes. Diya Ghosh is asking, how does type 2 diabetes affect the human heart? Heart is actually a organ which has multiple blood vessels, and as blood vessels in the diabetic patients get affected, and that's the reason there is a coronary artery disease. The coronaries of heart are getting affected because of the sugar level. That leads atherosclerosis, they can get blocked, and which can lead to heart attack and heart failure also. The heart failure other mechanism is there are smaller vessels. There are very, very small capillaries and vessels which are there in the heart, and they also get blocked, and because of that, heart pumping action is getting damaged, and that leads to heart failure in diabetic patients. So that's also a very common pathology behind a uncontrolled diabetes and diabetes heart failure. Ishika Shetty, she is asking how postprandial metabolism be benefited in type 2 diabetic patient. We are the one who are eating all the time carbohydrate. Our post-meal glucose level are always very high. To control that, one thing is the diet control. The carbohydrate portion in our diet has to be significantly reduced. As per international guideline, it should be less than 55%, but what we are eating is 75% of our diet, which we are eating is carbs only. So that restriction itself will help to get a good control of postprandial glucose level. But then there are a few medications which can be also used just to control the post-meal glucose level. The other question is that how has COVID-19 affected diabetic ketoacidosis rate in pediatric type 2 diabetes? In a two-way. One is that there could be a new onset. There could be a patients who are already prone to decay or uncontrolled diabetic. They may develop, but type 1 diabetic patients, many of them because of the fever or because of they are ill, they either reduce the dose of insulin or some of them had stopped, and that had led to diabetic ketoacidosis, which is a major problem. And we had seen many patients with diabetic ketoacidosis post-COVID, peri-COVID, or immediately after the COVID also. Rajiv is asking why alcohol abstinence is important in patients with type 2 diabetes. Alcohol overall abstinence is good for health because complete abstinence is the best, but those who are taking regularly, still there is always a risk of liver disease. In a diabetic patient and with metabolic syndrome, you are already at the risk of NAFL, non-alcoholic fatty liver disease, which is even without alcohol, we are getting a fatty liver. We are getting liver is getting affected, and that's the reason alcohol is one which we can definitely avoid in type 2 diabetic patient. What is the effect of SGLT2 inhibitor, particularly DAPA in patient with type 2 diabetes? SGLT2 inhibitor have a unique mode of action. They independent of beta cell. They don't work at the beta cell. They don't work at pancreas. The extra amount of glucose is getting excreted from urinary system. So instead of 180, which is a normal, it comes at 140. So above the 140 milligram, the glucose getting excreted, and that's how it is controlling the sugar level. It controls the post-meal glucose level. Indirectly, it will also improve the fasting. It will increase the insulin sensitivity, and it will decrease the weight also. How does metformin help with patient with dementia? Dementia is a condition and where we had also seen the higher the glucose level, they found to have more glucose, dementia. So there is a direct correlation between type 2 diabetes, metabolic syndrome, and dementia, and that definitely get benefited because insulin sensitivity improvement. Now more insulin will able to go to the brain cells, and that itself, that itself is a mechanism of how dementia can be better controlled with the patient who are on metformin. These are the people who have asked that this can be. Other than that, if anyone have any other question, they can type it. We'll be very happy to answer all those questions. And once again, thank you to TheRightDoctors.com for giving me an opportunity. If everything is fine, I can close it down. Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.